All right, so case 3 is CML with additional cytogenetic abnormalities, so something definitely to talk about. So here we have a 60-year-old man who presents with weight loss, weakness, fatigue, feeling full all the time, something's clearly not right. His past medical history, type 2 diabetes on metformin, hypertension again on propranolol, and with a left ventricular ejection fraction of 45%. He, on physical exam, is really unremarkable. So I guess we're saying there's no splenomegaly, there's no CML-related findings. And his presenting CML CBC, white count is 125,000, mild anemia, hematocrit 33%, and platelets normal at 290. So his cytogenetics, I think, the focus of discussion here. So there's a PH chromosome finding in 20 out of 20 metaphases, but as well there is deletion of chromosome Y and isochrome 17 and found in addition. Conventional molecular testing shows a transcript level 89% on the international scale. So I'll say diagnosis chronic phase CML and that the patient started on demand of 400 milligrams per day, but I think that's where we should stop and pause and look at this patient's presenting features and talk about it.
Thank you. Adam, can you talk to us about the role of cytogenetic testing here for this patient, how it might impact our treatment decisions?
I think it's interesting. So it opens up the broad topic for discussion of ACAs, additional cytogenetic abnormalities. I think it's important to segregate up front whether those ACAs are occurring in the setting of the PH chromosome or in the absence of the Philadelphia chromosome. I think we won't talk about the latter immediately, but focus on a patient who presents with CML, with the cytogenetic evidence of 922 translocation and an additional cytogenetic abnormality. We can dispense with a loss of Y immediately. I think it's important to know what percentage of cells have loss of Y. That may be a physiologic phenomenon or an aging phenomenon, although this patient is not that old. So that may not be necessarily indicative of cytogenetic progression. What I think obviously is indicative of cytogenetic progression here is the isochromosome 17q, and although we talk about 17q, it results, as we know, in loss of the P arm of chromosome 17 and takes out P53, which is a key step in the transformation of CML. I think the relevance of additional chromosomal abnormalities at the time of diagnosis can be discussed differently from those that emerge during therapy. So if we focus now on those that appear at the time of diagnosis, there are a number of different groups who interpret things differently, to my knowledge. So WHO, for example, will, if you have one of the 4 major root cytogenetic abnormalities at diagnosis, and those will be, if memory serves me correctly, isochromosome 17q, a duplication of the Philadelphia chromosome, trisomy 8 and trisomy 19, and 2 others, 3q26 abnormalities, or complex cytogenetics, the presence of one of those 6 abnormalities at the time of diagnosis indicates that the patient is in accelerated phase. Not every group believes that. I think the ELN pays less attention to the relevance of additional cytogenetic abnormalities, at the time of diagnosis. And I think there's also data to indicate that therapy with TKIs may be as effective in some settings with ACAs, depending which one is there, as compared with those individuals, those patients who do not have additional cytogenetic abnormalities.
Yeah, a comment I'll make is that the addition of cytogenetic abnormalities in the era where interferon was the drug was pretty clear. And we knew what to do with accelerated phase, and we understood it much better. Accelerated phase, or sort of the high-risk presentation in the era of TKIs, a little more challenging to know exactly how to specifically manage the patients beyond when they get a response. And again, one of the questions raised here might be, are we going to treat this person differently in folks' minds, knowing that they've got this really important additional cytogenetic abnormality?
In our practice, we are, in fact, especially with somebody who's having the isochromosome 17 or TQ26, we offer them frontline therapy with second-gen TKI. And then I will monitor carefully for the early responses, because these were like at 3 months or 6 months, I should act and not wait for longer time to assess for response and make my treatment decision or treatment adjustment.
Yeah, I think this is all data driven. I mean, I think data from your institution, data from the German CML study group have shown these major root abnormalities or select sort of bad actors, the chromosome 3 changes, X-chromosome 17. Those are definitely need to be addressed differently because the overall survival and the response expectations are noticeably lower. What a great point about, what does it mean in the era of TKIs? Very early on, there was some sense that imatinib response for patients with isolated clonal evolution, not clinical accelerated phase, could approach chronic phase. But now we've clearly dissected it down much further, and we know that all patients are not created equal. Many of these patients, for example, had trisomy 8, which is probably much different than isochrome 17. So we have to know what the abnormalities are, and we have that information here.